Okay, so the next few recordings are going to talk about blood vessels. So blood vessels will transport blood to the tissues where gases, nutrients, and waste are exchanged, and then back to the heart. They will also regulate blood flow to the tissues. Due to the smooth muscle within the walls of the blood vessels, they can actually perfuse a tissue more or less depending on its particular needs at any given moment. They can help to control blood pressure, again, by that smooth muscle. If you constrict the blood vessels, you can increase the blood pressure. If you dilate the blood vessels, you can help to decrease the blood pressure. They can also secrete a variety of chemicals. So we've talked about extensively already the two main circuits. We have the pulmonary circuit, which transports blood between the heart and the lungs, and the systemic circuit, which transports blood between the heart and the rest of the body. There are several different types of vasculature. Arteries, this is your distribution system, as they travel away from the heart, and that's their definition, is that they travel away from the heart, okay? They will branch into vessels of, they will continue to branch progressively in smaller diameter as the further you get away from the heart. And most will actually supply most of the tissues within the body with blood. Capillaries, this is your exchange system of vasculature. These are very small diameter blood vessels. They form branching networks called capillary beds. Gases, nutrients, waste, and other molecules will be quickly exchanged between the tissue, cells, and the blood through the capillary walls. Many of these capillary walls are actually only about a single cell thick. Veins is your collection system of the vasculature, and the purpose of this is actually to drain blood from the capillary beds and to return that blood back to the heart. Veins typically follow the opposite pattern that is seen of that of arteries. Smaller veins will merge into other veins to become progressively larger vessels as they move towards the heart until you end up with the superior and inferior vena cava. Now, all three blood vessels will contain pretty much the same three layers. An internal layer called the tunica intima, and middle layer, tunica media, which is primarily going to be smooth muscle, and an external layer called the tunica externa. The innermost, the tunica intima, this is composed of endothelium. It is continuous with the inner lining of the heart, which, if you remember, is called the endocardium. The endothelial cells provide a smooth surface over which blood can flow with minimal friction and turbulence. It's actually when you have scar tissue, plaque buildup, in which blood flow becomes more turbulent, which could be detrimental. This is a thin layer. You have a thin layer of subendothelial connective tissue and a layer of elastic fibers called the internal elastic lamina that is deep to the endothelium. And this allows for a little stretch and recoil there. The elastic fibers will give the vessel properties of distensibility, the ability to stretch, and when subjected to increased pressure and elasticity, the ability to recoil back to its original size when that force is actually removed. The middle layer of the blood vessel wall is called the tunica media, and this is composed of two layers with the following features. As I mentioned a few seconds ago, this is primarily going to be a layer of smooth muscle cells arranged in a circular manner around the lumen, which is the opening of the blood vessel, to another layer of elastic fibers called the external elastic laminar. The smooth muscle cells of the tunica media will control the diameter of the blood vessel and therefore the amount of blood that flows to the organs. Smooth muscle cells are innervated by the sympathetic nervous system. Nerves will stimulate smooth muscle cells of the tunica media to contract, and that's referred to as vasoconstriction. When sympathetic stimulation of smooth muscle cells decreases, the cells relax, and that can increase the vessel's diameter, referred to as vasodilation. The outermost layer is referred to as the tunica externa, and this is composed of dense, irregular, collagenous connective tissue. The purpose of this layer is to support blood vessel and prevent it from overstretching. The vasa vasorum, these are tiny vessels supplying oxygen and nutrients to the tunica media and tunica externa. Cells of the outer layers of the large blood vessels are too far away from the lumen to receive oxygen and nutrients by diffusion alone. And the vasa vasorum will help to supply that, for example, that smooth muscle, which is going to require blood supply for its activity. One thing to note is that the structure of the blood vessel wall, the inner epithelial tissue lining, the layer of the connective tissue, the layer of the smooth muscle tissue, and the additional outer layer of the tough connective tissue is a pattern that you typically see repeated in a lot of hollow organs. And, you know, as we start going through each of these organs, you'll see very similar lineup, especially, for example, when we talk about the GI tract, the kidney tubules, things like that. You'll see very similar structure of note. And here we can see this would be the tunica interna. Here's the smooth muscle for the tunica media, and then we have our tunica externa. So now we want to note a few different differences between arteries and veins. Most arteries have much thicker tunica media than do veins. This reflects arteries' role in controlling blood pressure and also the blood flow to the organs. The internal and external elastic lamina are much more extensive in arteries than in veins. This reflects the fact that the arteries are under much higher pressure than veins as well. And here, if you look, you can see that the wall is going to be much thicker, but the lumen is actually going to be much larger in veins. The wall is going to be much thicker in arteries. Okay. Here we can see, you know, this is an artery right here, nice thick wall. Here's the lumen, much wider. Okay. And, you know, part of this is you're going to have much higher pressure here, so you need that thicker wall, especially that muscle, to be able to protect for that. And the reason why the lumen being larger here is good is because the pressure is much lower here. You want less resistance. So we're going to look at a few different types of arteries. We have what are referred to as our elastic arteries. These are the major arteries coming directly off the heart. Then we have muscular arteries. These are referred to because of the extensive smooth muscle network that's present there, which controls perfusion to a particular structure or organ. So these are really your feeder arteries into individual structures. And then the arterioles are just very small arteries. So the elastic arteries, these are your conducting arteries. They are the largest in diameter. This will include the aorta and its immediate branches. It's nearest to the heart and therefore under the highest pressure of any vessel in the system. The muscular arteries are your distributing arteries. These are generally intermediate in diameter. They contain well-developed tunica media, composed primarily of smooth muscle cells. Most smaller branches off the aorta are muscular arteries, and they are typically named for the organs in which they are going to supply. Your arterioles, these are the smallest arteries. They contain all three layers of blood vessel wall. The layers are extremely thin, and a tunica media only contains 1 to 3 layers of smooth muscle cells. The smallest arterioles, which are metarterioles, these are going to directly feed into capillary beds in most tissues. Smooth muscle cells of the metarterioles are confined mostly to the circular precapillary sphincter, which encircles the metarterial capillary junction, and that will regulate whether you perfuse that capillary bed or not. Certain arteries can also play a role in monitoring blood pressure and detecting concentration of certain chemicals in the blood, and therefore will have different types of receptors. There are various pressure receptors, which are called baroreceptors, that are in the aorta, as well as the common carotid artery in the neck. This is an important artery too because it's actually going to supply up the head towards the brain. Also in the carotid artery and the aorta are groups of chemoreceptors. These chemoreceptors will detect blood, oxygen levels, carbon dioxide levels, and hydrogen ion concentrations, which is important in the maintenance of blood pH. Veins typically will outnumber arteries in their tunica lumens, in their lumens, and have larger average diameter and have the following characteristics. 70% of the total blood in the body is located within the venous system at any given moment. This includes both systemic and pulmonary veins. This allows for veins to function as a blood reservoir because blood can be diverted from the veins to other parts of the system if needed. Veins typically have much thinner walls, fewer elastic fibers, less smooth muscle, and much more larger lumens. And again, the larger lumens is to help reduce the resistance because of the lower pressure that we find in that particular area. This sort of just shows you where blood is at any given moment in the body. So with the veins, they are classified by their size. You have venules. These are the smallest veins. They drain blood from the capillary beds. Tiny postcapillary venules consist of a little more than the endothelium and some surrounding connective tissue. The structure enables them to exchange material with surrounding interstitial fluid. Three tunics become more distinct as the venules merge to become larger venules and then eventually into actual veins. Most veins will have a thin tunica media with few smooth muscle cells. Their diameter changes only slightly with vasodilation and vasoconstriction. Many veins will contain venous valves. These are extensions of the tunica intima, which will overlap and prevent blood flow from flowing backward in the venous circuit. This is especially numerous in the veins of the legs, where blood flow towards the heart is strongly opposed by gravity. And one thing that you'll see is the pressure is extremely low on the venous side. And you want to keep blood moving in a one-way direction. And unfortunately, you are contending with getting blood back up from your feet, back up to the heart, which is going to go against all principles of gravity. So here we see our elastic arteries, muscular arteries, arterioles, venules, and veins. So just know the general characteristics and functions of each type. Atherosclerosis, this is the leading cause of death in the developed world. It affects large and medium-sized muscular arteries, characterized by the formation of atherosclerotic plaques, or the buildup of lipids, cholesterol, calcium salts, and cellular debris within the arterial tunica intima. Plaques tend to form in regions where blood undergoes sudden changes in velocity and direction of flow. Branching points are where the blood vessel tends to curve. Current evidence does suggest that plaques are generated in response to some sort of injury to the endothelium by high blood pressure, certain types of cholesterol, previous infections, toxins in cigarette smoke, high and prolonged blood glucose levels, and high blood concentrations of chemicals called homocysteine. The vessel wall becomes inflamed, which going to attract phagocytosis in an attempt to clean up the area. This actually results in damage to the blood vessel. Eventually, the damaged area turns into a plaque. The plaque is located in the tunica intima, but changes also occur in the tunica media. Smooth muscle cells will proliferate and secrete an extracellular matrix with protein fibers and ground substance that surrounds the plaques. If a plaque is exposed to blood, the clot may form in the vessel and obstruct blood flow entirely, as this occurs in a myocardial infarct or heart attack or a stroke. An estimated 10% of the world's population does have atherosclerosis. True prevalence is difficult to determine because most patients do not display symptoms in the early stages. Much treatment for atherosclerosis focuses on reducing factors that injure the endothelium. This definitely includes dietary modifications, increasing physical activity, any agents to help lower cholesterol, such as statins, control of blood glucose levels, important for diabetics, making sure that they keep their A1C at a lower level, smoking cessation, and management of high blood pressure. In severe disease, surgery or other invasive procedures may be necessary to open or bypass occluded vessels. Now, vascular anastomoses, these are locations where the vessels connect via pathways called collateral vessels. In arterial anastomoses, these exist in many organs such as the heart and brain, as well as around joints. New arterial anastomoses can be formed when blood flow through an artery is insufficient to meet the tissue's metabolic needs. And if the tissue is demanding more, you can actually sort of increase blood flow to that, increase blood vessel by these anastomoses, and therefore increase blood flow to those areas. Venous anastomosis, this is a common type of anastomosis. Neighboring veins are connected by small collaterals. Smaller veins are often so interconnected that they form complex web-like patterns. Arterial venous anastomosis, this is when an artery empties directly into a vein without passing through a capillary bed. Okay. Okay, so now we'll look at some of the physiology of blood flow. Hemodynamics, this is a physiology of blood flow in the cardiovascular system. And the basic concepts are that things operate based on gradients, whether it's concentration gradients, pressure gradients, or electrical. These will drive most processes within the body. The heart provides the force that drives the blood through the blood vessels by creating a pressure gradient. Pressure is highest near the heart and decreases as blood moves further away. Blood flows down the pressure gradient from an area of higher pressure near the heart to an area of lower pressure in the peripheral vasculature. Blood pressure is the actual outward force that is exerted on the walls of the blood vessels. It is typically expressed in units of millimeters of mercury. The force exerted by the column of mercury in 1 millimeter in height. This can vary dramatically in different parts of the vasculature. However, it is typically highest in large systemic arteries and lowest in large systemic veins. The magnitude of blood pressure gradients is one main factor that determines blood flow. The amount of volume of blood that flows per minute. Generally, blood flow matches cardiac output, where it averages somewhere between 5 to 6 liters per minute. Blood flow is directly proportional to the pressure gradient, meaning blood flow increases when the pressure gradient increases, and vice versa. Another factor that can help determine blood flow is that of resistance. This would be any impedance to blood flow. Blood flow is inversely proportional to resistance. Therefore, as resistance increases, blood flow will decrease. Velocity with which blood flow is largely determined by the cross-sectional area of the blood vessel. As arterial systems branch into progressively smaller vessels, the total cross-section will increase. This increase in the area causes the velocity of blood flow to decrease. For this reason, the velocity of blood flow is fastest in the aorta, slowest in the capillaries, and will actually pick up speed in the veins. So the further, as you start to branch out more, if you look here, your total cross-section was 5 centimeters in an artery. The arterials, you have 2, 4, 6, 8, 10, so you've actually decreased, you've increased your cross-sectional anatomy by 2, which will decrease the overall speed. The decrease in speed at this level 2 also allows for gas exchange to occur, because once you get to the capillaries, you're really increasing the cross-sectional anatomy significantly. And again, that allows for a little time for exchanges to actually occur. Okay, so some factors that can determine blood pressure. There are 3 main factors that can influence blood pressure, and that is resistance, cardiac output, and blood volume. Peripheral resistance is any factor that hinders blood flow through the vasculature. This contributes to the overall resistance of that circuit. Vessels near the heart will contribute little to overall resistance, and the resistance is greatest further away from the heart, for example, in the body's periphery. As peripheral resistance increases, blood pressure will also increase. The blood vessel radius, this is a resistance that varies inversely with the vessel's radius. This is resistance that varies inversely with the vessel's radius. As the radius increases or dilates, the resistance of blood flow decreases, and vice versa. If it constricts, the blood flow will increase. Viscosity is defined as an inherent resistance that all liquids have to flow. The more viscous a liquid is, the more its molecules resist being put into motion and staying in motion. Blood has a high viscosity due to a number of proteins and cells that it contains. The length of the blood vessel, the longer the blood vessel, the greater the resistance. More pressure will be needed to propel blood through a long vessel than a short one. One reason why resistance in the pulmonary circuit is so much lower than that in the systemic circuits. Cardiac output. We talked about cardiac output as a product of stroke volume and heart rate. Cardiac output and peripheral resistance are two factors that determine pressure gradient that drives circulation. And that relationship is expressed as cardiac output times peripheral resistance and the change in pressure. When cardiac output increases, blood pressure increases, and vice versa. The final factor that can determine overall blood pressure is the volume of blood in the circulatory system. The total volume of blood is directly linked to the amount of water in the blood. When blood contains more water, blood volume increases. As volume increases, blood pressure increases, and vice versa if you take it through the other path there. Small increases in blood volume are offset by the ability of the vessels to actually stretch, and this allows for a certain level of compliance. Veins are most compliant vessels. They stretch to accommodate the added fluids when blood volume increases, with only a small rise in the actual pressure. So again, here you can see various factors that can influence blood pressure, whether it's the vessel radius, the viscosity, the blood vessel length, any obstructions, the stroke volume, heart rate, water loss, water gain, and what that's going to do to the overall resistance, cardiac output, and blood volume will determine how it affects the overall blood pressure. And you sort of wanted to think through these various pathways here. So blood pressure remains fairly low throughout the pulmonary circuit. However, blood pressure changes significantly as blood travels through the systemic circuits. Blood pressure in two circuits are dramatically different, averaging about 15 millimeters of mercury in the pulmonary circuit and about 95 millimeters of mercury in the systemic circuits. When you look at systemic arterial pressure, the pressure profile of the entire systemic circuit is highest in the aorta and the elastic arteries and declines slightly as it spreads throughout the muscular arteries. There's a number that they look at which is referred to as the mean arterial pressure. This is the average pressure in the systemic arteries during an entire cardiac cycle. And as I mentioned, it's typically about 95. The heart has both contraction and relaxation periods, so pressure gradient is generated by the heart when it pulsates, rising during ventricular systole and declining during ventricular diastole. This will lead to two separate pressures in the arteries. The systemic pressure, which averages about 120, and the diastolic pressure, which averages about 80 at rest. The differences in the systolic and the diastolic pressure is 40. This is referred to as your pulse pressure. The arterial blood pressure is usually measured in an arm where they will generally determine with a sphingomanometer and a stethoscope. To determine the mean arterial pressure, you want to take the diastolic pressure plus 1/3 the pulse pressure. The diastolic pressure, again, would be 80 plus 1/3 the pulse pressure, which is 40. And that will give you your typical map. And I said it's typically somewhere around 93 to 95. So say we have a very distensible artery that contains no blood. It's completely empty, as in part A on the next figure here, okay? The artery will take on a certain resting size due to the smooth muscle in its walls. But now let's say we add a really large volume of blood into the vessel, as shown here. The artery walls will stretch and it changes in size. Why does this happen? Because blood is putting pressure on the artery walls. Now let's apply this to circulation. When the left ventricle of the heart is in diastole, arteries resemble part B. Ventricles isn't forcing blood into them, so blood puts less pressure on the walls. So why diastolic pressure is smaller, why diastolic pressure is a smaller number. Conversely, when the left ventricle is in systole, arteries resemble part C. The ventricle is forcing more blood into them, so blood puts more pressure on the walls, and that's why we see systolic pressure is a higher number. Size change repeats with each cardiac cycle. Pressure gradients generated by the heart pulsates, but the artery itself also pulsates. You can, of course, feel this in certain arteries close to the skin, and this is typically where we take our pulse, and these are known areas. When we consider blood pressure in terms of blood actually pushing against the vessel walls, it becomes easier to understand the factors that determine blood pressure. With cardiac output, if the cardiac output rises, the ventricles are going to force more blood into the arteries. This will make the blood press more forcefully against the vessel walls. If we increase the blood volume, it's likely trying to add more air to a balloon. The vessel wall will stretch to accommodate the extra blood, but eventually the vessel won't be able to expand anymore, and the blood will simply put pressure on its walls then. And then if we also decrease the size of the vessels due to resistance, but have the same volume of blood, it's likely trying to fit a certain volume of air into two small balloons. Blood doesn't have much room to move, and again, it pushes more on the walls with a greater force. Pressure doesn't change much in the pulmonary circuit, as it remains fairly low from the pulmonary artery to the pulmonary veins. However, pressure does change significantly as blood travels through the systemic circuit. If you look here, looking at the pulmonary arteries, it's about 15, pulmonary veins is about 5. In the systemic circuit, your arteries are going to range between 120 over 80. The arterioles will go from 80 to about 35. Capillaries are going to be about 35 to 15. You got to get down pretty low too when you get to capillaries, because these are very thin-walled blood vessels, and if the pressure's too high, you'll blow right through those blood vessels. Now, there is no pump there to increase that pressure. So you're coming out of the capillaries at 15, which means you're entering into the venules between 15 and 5. And this will continue to decrease until you get to pretty much the vena cavas, which is going to be pretty much at 0. The pressure at the arterial end of the capillary is approximately the same as the small arterioles, and that's about 35. However, at the venule end of the capillary bed, the pressure has decreased to about 15. This pressure decreases is largely due to a reduction in blood volume and takes place in the capillaries. And here you can see those fluctuations. Again, within the aorta, the elastic arteries, and even the muscular arteries, you can see this pulsatile nature with pressure. Once you get into the arterioles, that stabilizes out the pulsatile nature of the pressure, but it's also where you're going to drop off that pressure significantly. And then it continues to fall as you go through the capillaries, the venules, veins, and then ultimately the vena cavas. So the pressure will decline even further in the venules and veins, dropping to about 4 in the inferior vena cava and as low as 0 in the right atrium. Low pressure is largely due to the high compliance of the veins and declining resistance as blood vessels merge to become larger. Venous blood must be returned to the heart at the same rate that it is pumped into the arteries. The venous circuit is under such low pressure that there isn't much of a driving force to propel the venous blood back to the heart. You have these valves that prevent backflow in some veins. Smooth muscle in the vein walls can contract under sympathetic nervous stimulation to actually help to stimulate the increased rate of return. And then you also have what we refer to as a skeletal muscle pump. This is skeletal muscle surrounding deeper veins of the upper and lower limbs will squeeze the blood in the veins and propel it upward towards the heart as they contract and relax. So essentially when the skeletal muscle contracts, that's going to squeeze on the actual veins and you will actually propel the blood. And with the valves in place, that will help prevent any backflow due to gravitational pull. We also have what's referred to as the respiratory pump. This helps to propel blood through the thoracic and abdominal cavity veins. This is driven by rhythmic changes in pressure in the thoracic and abdominal pelvic cavities that occurs with ventilation. So during inspiration, high pressure in the abdominal pelvic cavity will create pressure gradient that's going to push blood in the abdominal veins upward. Low pressure in the thoracic cavity will allow thoracic veins to expand. During expiration, the abdominal veins will expand and fill with blood while the thoracic veins are squeezed. And that is it for recording number 1.